Hi, Emma.
Hi, Jonathan.
It's time for Cut
the
the
Case.
Case. And Emma, I've got a case for you. It was a tricky case, this one. I'd be interested to see how you'd manage it. There's a couple of bits to it. There's a bit of trauma, but there's a bit of something else.
Okay,
And
go
it's a
ahead.
bit of something else that's important, I think. So I've got a guy. I'm called to see a gentleman. He's in resus. He's 47. He's had some sort of throat injury, and it sounds like he's been involved in a assault, but he's not really very forthcoming. He's either been punched in the throat or, strangled or
Strangled.
something like that.
It's a relatively protected area, isn't it?
Well, this is the thing, right? So, and the only injury seems to be his throat. And he's sitting up there in resus, with monitoring on. He looks okay.
But he's sitting up. Why is he sitting up?
And that's the thing, right? And I just wanted to just go through some of the things about how you assess someone who might have a laryngeal injury, because that's what I'm worried about.
Okay.
So what do you do when someone's got, concern for laryngeal injury? What's your assessment, Emma?
Well, I guess it starts with history, doesn't it, Jonathan? So you're really wanting to know about the mechanism of injury?
There's not much history.
Okay.
I was minding my own business and something bad happened to my neck.
Okay.
That's all you're going to
Okay.
get.
So, part of your history is you want to know about risk factors, I guess, that would make things worse. For example, has he got any other disease, for example, cardiorespiratory disease? Is he immunocompromised? Because then you might be wondering about an infection or other complications, but you also want to know about medications and, are they anticoagulated, for example?
Exactly. Or is he got ITP or low plates or something like that? Now, none of that's really forthcoming. He seems like a pretty fit and well 47-year-old guy.
Yeah. And you probably want to know a little bit about the history. So, the time. So are things worsening over time?
Yeah. It doesn't seem like things are worsening. It seems like he's had maybe one punch or one event. There was
Which he won't tell you about?
Won't really tell me.
Well, if he would tell you, what you want to know about is what kind of pressure. Was it sustained? Was he held up against a wall, for example?
And so that's really important, the held up against the wall thing, isn't it? Because that
the full weight around the neck.
The explanation.
Was it an attempted hanging? Does
full
this
weight
patient
around
need a mental health assessment? There's so many ways.
There's
that
a
this
lot
could
of
go.
stuff, because that might give me reasons to do a CT or not.
I think what you're describing to me through probably non-verbal cues from this patient is that he didn't want to disclose an assault because there was something dodgy going on.
And that's a common thing. People don't want to. So history aside, we don't have a lot of history. Examination, I've said he's sitting up. He's not hypoxic. There's no obvious stridor. He looks okay.
And his voice?
Yeah, it's not quite right.
Okay, so he's got a hoarse voice?
It's a little bit soft.
Okay.
It's probably hoarse. Okay. Has he just been to the footy and he's been shouting? I don't think so. There's a change in his voice. It's a change in his voice.
Can he swallow?
I think that's the thing. He can swallow, and he really wants to swallow. He's really keen on getting something to drink. He's really thirsty. And he's had a bit to drink already.
All right.
That's the other thing.
Okay.
He's intoxicated.
Okay.
So he's intoxicated with a hoarse voice, with a story concerning for a laryngeal injury or a throat injury.
I guess there's some additional supportive things that you could look at. You could look at petechiae in the face, subconjunctival hemorrhage, any other trauma.
Why?
Because you can get pressure around the neck, causing venous congestion, vomiting, choking.
Signs of prolonged venous congestion, I guess. Was he actually strangled? And that might be something. He's got none of that.
And then local signs. So you're really looking at expanding hematomas, bruits,
no
dissection.
Hematoma, not even a red mark, Emma.
Okay.
He's a bit tender, but I think most people are tender. I'm feeling for crepitus. I'm just feeling for the general shape of the larynx. Is it all out of place? Is there crepitus? Is it subcut emphysema? It's a little bit tender.
And then you'd be looking in the mouth to see if there's any evidence of trauma there. So
there's nothing in the mouth. So what do you do with that sort of guy?
Okay, so you've got a suspicion, you've got voice change, you may have some other signs that suggest, and you've got an unknown mechanism. So you're worried about this guy.
So it could be really bad. It could be trivial.
So you want to get some investigations, I think.
What do you test? So what are options? It's going to be CT or ENT.
Yeah.
And hey, that even rhymes. So it's after hours, ear, nose and throat. They're coming, but can you get the CT, please?
Well, can you lie flat?
Can't lie flat.
Okay. That's tricky.
So I arrange a CT.
Yeah.
And ENT are on their way. And it's all lined up. And I go and see another patient.
I'd be worried about him if he wasn't lying flat.
I'm worried.
Yeah.
I am worried. He looks okay, but I'm worried. And we know that about half of serious laryngeal injuries actually have no signs at all, or just have a hoarse voice.
Yeah.
So history is super important. Now let me cut to the case, Emma. He CT's lined up. We're going to try and lay him down to do it.
ENT's coming
ENT's coming.
to do a nasal endoscope.
Nasal endoscope to have a look, because that's the other test,
And I'm presuming you've done a full trauma assessment. He has no other
Absolutely
injuries.
full
Great.
trauma assessment, Emma, of course. Then I get the call. He wants to leave.
Uh-huh.
He doesn't want to stay.
Okay.
I'm sick of this place. You want to lay me flat. You haven't given me anything to drink. I want to go.
Okay. So
What
how do
do
you
with
respond
that?
to the
Yeah.
patient that wants to leave?
So this is the thing now, and I'm concerned, right? So ordinarily, okay, nothing wrong. You can leave. You can follow up with the GP. I'm not worried. But in this guy, I'm concerned for serious injury, serious sequelae in the next 12 hours.
Well, I would encourage you, Jonathan, for any patient that wants to leave, that step one is you go to that patient. Step two is you try and understand
Of course, I'm
why,
what do you mean?
why they want to leave. So, simple question, why do you want to leave? So go to the patient, why do you want to leave?
Yeah.
And then you try and do a couple of interventions. So enlist support of family and friends, or deal with the reason that they want to leave. Is it their dog, cat?
Which is often, usually a lot of the time you can just deal with it then and there. What is it that you need to go home for? I'm not really getting a good story as to why he needs to leave.
Yeah.
There's not a really good reason. I just want to go. I don't want to stay.
And then there's comfort measures that you can try and do. So are they hungry, thirsty, which he's not going to be able to eat and drink, unfortunately. Does he want a cigarette? So you may actually encourage him to either use a nicotine replacement therapy, or worst case scenario, maybe he has a cigarette.
And surprisingly, that is often the thing that that's the deal breaker. If you could just give him a cigarette, they'd be fine. I'm not giving this guy a cigarette, but if I can give him nicotine replacement, he might be all right. He wasn't okay with that. But I did enlist some family. So I've got some family on the line. They're also worried too. He's been missing, this guy. He went to the pub and now he's in hospital. They're coming in. So I've now bought myself a little bit of time.
Because maybe he'll just leave.
Maybe,
in which case you need to do
it's a capacity assessment.
So what are the steps in a capacity assessment?
Well, I knew you were going to ask me. That's why I'm asking you, Emma. So I guess step one, is he actually with it enough to understand what I'm trying to get across to him? So can he understand?
So I'm concerned about an injury to your voice box that can affect your breathing. And so really you're testing whether or not he can understand that. And then can he retain that information?
To retain it. So am I just telling you something and you're not listening, you're not registering? I need to satisfy myself that he's actually registering what I've told him. So he needs to be able to retain it. And that might just come, the example might be, can you just repeat back or just explain to me, did you hear what I said? Let's just go through what I just said. Can you just repeat it back to me? And then I'll know he was able to retain it. Now, he did retain it.
And then you want to test whether or not he's rationalizing the information according to his values. So, yes, I understand my voice box is injured. However, I really need to get home because I actually don't care about my health. I care about my dog above everything else.
And this is often where it comes a little bit unstuck because it's health values, right? So people, maybe they don't understand the depth of my worry, I suppose. What I'm trying to say is you could die because you're in hospital and we can do amazing things, but if your larynx is crushed or your airway is obstructing,
it's an unpleasant death.
It's an unpleasant death, but also we may not be able to prevent it despite our best efforts. You might end up with a surgical airway. I might not be able to intubate you to put the breathing tube in. So you need to go into that kind of detail.
And then the final step, just to close off the capacity assessment, is being able to communicate those thoughts and feelings back to you. So understand, retain, rationalize according to your values, and then communicate that back to you. So how did he go? Thankfully
for us, for my reassurance, I was able to explain to him eventually that things were going to get worse, and he was really afraid of that.
Okay.
When I told him that if he went home and he lived a fair way away, he might actually be in a whole lot of trouble. His partner comes in, she's worried too. We enlist support, and we do a deal.
Okay.
You're going to stay overnight.
Okay, and what did he end up having?
He was still in the morning. He had laryngeal fracture. So the ENT came in. Eventually, we got him to lie flat. Some analgesia. He had a significant laryngeal fracture.
Okay.
And had to have that, looked at by ENT. So he didn't actually do too badly. He was okay. That was the story. So a really, like, it's not a common injury.
Hemoptysis, sorry, is one of the things that you.
Thanks for reminding me.
I'm just thinking back through the cases of laryngeal fracture that I've seen, and we did neglect to mention that.
Probably haven't seen a lot. It's not that common.
No. But enough.
Yeah. So again, the history is important. It's also important to know you may not find much on examination. Just be aware in a laryngeal injury, a hoarse voice is a really good pointer as to what the problem is. And then there's that capacity assessment and the four bits to that. What are they again, Emma?
I'm going to go backwards. Communicate, rationalize, retain, and understand. So understand, retain, rationalize according to your values, and communicate it back to you. One of the other things that we should state is actually this is an injury that often happens in women, and it's often in relation to domestic violence, and it really should be a red flashing light to suggest that this is a patient at high risk of fatal injury.
Yeah, absolutely. This is
in the future.
This is, the one we need to be aware of, and the mere fact that you don't see much and you just get a hoarse voice is very tricky. So it's really serious.
And non-fatal strangulation, but in the future that puts them at high risk of death from.
The last thing I would say with this, document. This is all about documentation too. So not only documenting what I found on examination, my concerns, but then the capacity to make a decision. And if it was domestic violence, obviously there's more documentation that needs to go there.
Well done, Jonathan. You passed.
Okay.
You put in that documentation.
Well, thank you, Emma. All right. Thanks, guys. We'll see you next time. Bye.